Okay, so hi everyone. Thank you so much for joining us today for the 2026 MPSPA Year in Review webinar. My name is Daniela. I'm a researcher at the University of Calgary in Canada, and I am joined by Dr. Fabrizio Ferreira de Oliveira from the University of São Paulo in Brazil, and we will be your co-moderators for today. We have one speaker, Dr. Matthew Kang, who is a consultant neuropsychiatrist at the Neuropsychiatry Centre, Royal Melbourne Hospital, with a clinical focus on younger onset dementia. He is completing a PhD at the University of Melbourne and coordinates a multi-site study examining blood-based brain biomarkers in severe mood disorders. He is a 2025 ISTAART ambassador with research interests centered on neuropsychiatric symptoms across the dementia disease course, linking biomarkers, symptoms, and clinical care. We also have 5 panelists. We have Professor Muireann Irish, who is a professor of cognitive neuroscience and a National Health and Medical Research Council of Australia professorial fellow based at the University of Sydney in Australia. Her research focuses on understanding early cognitive behavioral and neuropsychiatric changes in younger onset dementias with a view to improving early detection and symptom management. She leads the MOTDEM initiative, bridging together researchers, clinicians, and people with lived experience to transform the early and accurate diagnosis of younger onset dementia. We also have Dr. Amer Burhan, geriatric psychiatrist, endowed researcher chair, and associate professor in psychiatry at the Ontario Shores Centre for Mental Health Sciences and University of Toronto Tamurti Faculty of Medicine in Toronto, Canada. His work focuses on clinical trials for cognitive, behavioral, and gait abnormalities across the spectrum from late-life depression to advanced Alzheimer's disease. Other areas include the utilization of technology and advanced analytic tools like machine learning to improve measurement predictions and clinical course and treatment response, as well as caregiver interventions leveraging simulation in the virtual space. We also have Dr. Blas Couto. He's a neurology specialist, currently working as a clinician scientist in the Institute of Cognitive and Translational Neuroscience, or INCYT, and Fevelero University, Buenos Aires, Argentina. After completing his PhD in neuroimaging and his neurology residency, he did a clinical fellowship at the Toronto Western Hospital in Canada, acquiring broad expertise in diagnosis of rare movement disorders and progressive supranuclear palsy, cortical basal syndrome, and their neuropathology. He is a member of the Argentinian Neurological Society, lead of the Movement Disorders Study Group, the International Parkinson's and Movement Disorders Study or Society, and the Alzheimer's Association. Currently, he performs epidemiological research on PSP under the mentorship from Dr. Connie Marsand and leads a lab with a full team of students. His career goals are to improve dementia clinical research in the region of South America. He also leads the Consorcio Argentino para Investigación en Taupastillas Primarias, recruiting patients with PSP and CBS, including clinical and biospecimen data. We also have Dr. Ganesh Babalal, who is an associate professor of neurology at Washington University School of Medicine and director of the DRIVES Project and ARCHES Laboratory. His research investigates the relationship between cognition and mental health and its impact on instrumental activities of daily living, like driving in healthy older adults and those with chronic neurological diseases. Federal and private foundations have continuously funded Dr. Babalal's research on biomarkers and mood in preclinical and prodromal populations since 2014. We also have Dr. Catherine Monroe, who is a clinical neuropsychologist at Mass Gen in Brigham and Harvard Medical School. In addition to seeing patients, she performs clinical research evaluations for several observational research studies through MGB/HMS. Her research currently funded by an Alzheimer's Association Research Fellowship Award, primarily focuses on neuropsychiatric symptom trajectories and associations with Alzheimer's disease biomarkers in early preclinical and prodromal stages of AD. So without further ado, let's welcome Dr. Matthew Kang.
Thanks, Daniela. Sorry, shut some stuff. So my name is Matt. I am from Melbourne, and I have had the pleasure of meeting some of you last year in my purple shirt as one of the ISTAART ambassadors. My wife did joke whether I should put that on today, but I held off on that. Mainly, though, I work clinically with people affected by young onset dementia. I'm also doing a PhD in research in blood-based biomarkers in this group as well. And this PIA for neuropsychiatric syndromes is a passion and an interest of mine, given the overlap between psychiatry and neurology, the brain-mind interface, but really it's clinically relevant. It's important to patients and families that I work with, and the research is ever so evolving, which hopefully I'll share some of today. I have no disclosures to note, screenshots encouraged, and there will be a webinar recording recorded and available on the ISTAART website. Now, just as a background for some of you who may be newer to the area like I was, I'll just go through some of the terms that's going to be used in the presentation, just so that we're all on the same page, because they can be used differently depending on which area you work in. I guess the first idea that comes from this PIA is mainly that dementia is not just cognitive impairment. There are many, many other symptoms that are present in dementias, including Alzheimer's disease, but other related dementias as well. That range from depression, apathy, or agitation, behavioral symptoms, and they're all encompassed under this term of neuropsychiatric symptoms, or NPS, that you'll see here. And these are symptoms specifically associated with dementia when we refer to it in this presentation. There are other terms similar or akin to NPS, and the other one mainly uses BPSD, or behavioral and psychological symptoms of dementia. These often denote sort of the more moderate to late stages of dementia-related behaviors and psychological symptoms, including agitation and aggression. And again, it's a more encompassing term. The other term that's newer and I guess more hot in terms of the topic is MBI, or mild behavioral impairment. And this is a paradigm that behavioral symptoms often precede cognitive symptoms or memory symptoms, and that these behavioral or personality changes, especially after the sort of the middle life, sort of after 50 years old, that are persistent for more than 6 months, and have higher risk of developing dementia later on. And they sort of divide the domains to apathy, mood and anxiety, impulsivity, social cognition, and psychosis. I could talk sort of for a lot longer if I had time, but there are some great resources available on the ISTAART website, including the previous year in reviews, and I would encourage you all to check them out if you have time. There's also, and this is the first article I introduced today, two of the previous speakers have published a narrative review about neuropsychiatric symptoms in AD. That's available at Alzheimer's and Dementia Journal now. And so now for this talk today, on a similar note of the previous years, I've conducted a systematic search of all of the literature available in the year 2025 that's focused on neuropsychiatric symptoms related with dementia. But in saying that, I've encompassed, or as previously we've encompassed the clinical spectrum from cognitively normal, subjective cognitive decline, MCI, MBI, and clinical dementia. And of the sort of 500-ish papers that were remaining, lots of themes came out like previous years. And I think it really speaks to the diverse nature of the neuropsychiatric symptoms, but also the heterogeneity inherent in this syndrome. Instead of trying to cover all the topics, and I didn't want to keep you for too long, I've really distilled down these topics into 5 themes to really highlight the evolving field of where the direction of neuropsychiatric symptom research in Alzheimer's disease and related dementias is moving to. It also sort of highlights or exemplifies my understanding, my increased understanding of neuropsychiatric symptoms research and how the field is evolving at the moment. And I'll go through each of these themes, explaining what they mean, but also the key papers associated with these. And to highlight also that although I won't be only able to highlight 1, maybe 2 papers per theme, there were so many other papers to choose from that I was actually picking and choosing which studies, even just minutes before this presentation started, because there is so much great research out there. So the first theme that I'll cover is highlighting the wide range of AD biomarkers that we use in neuropsychiatric symptoms to better understand them, as well as how we might use them when we face neuropsychiatric symptoms in clinical practice. So as most of you are probably familiar, biomarkers have had massive breakthroughs in recent years, especially last year rather, with the FDA approval of p-tau 217 as a blood test to diagnose Alzheimer's disease. But biomarker use for MPS research has mainly been hypothesis generating, and the research last year was consistent that AD biomarkers are related to MPS and MBI types. For example, MBI apathy subtype is linked with CSF Alzheimer's disease biomarkers. Apathy is longitudinally associated with increased rate of NFL rise, a general marker of neurodegeneration. And these findings appear to be consistent in other cultural settings, including the Congo population. This research, and the byproduct of these developments of these biomarkers, including sort of fluid, but also PET imaging biomarkers, is that they've really consolidated neuropsychiatric symptoms aren't just psychological reactions to dementia. They're potentially prodromal biological biomarkers that we can use to predict years before cognitive decline and dementia diagnosis. And so with that concept in mind, this study really stood out to me by Liao et al. This was a study based in Singapore where they followed up about 300 people who were dementia-free, cognitively normal for 5 years, of which about a quarter developed mild behavioural impairment or MBI. The key finding was that the baseline blood p-tau 181 was significantly higher in those who developed MBI over time. And the other interesting part of this study was that it was validated in a non-white/Western population, as a lot of the research is based on the ADNI database. And so this study really raises the interesting possibility of, could AD blood tests detect MBI in asymptomatic populations long term? And related with that paper is this narrative review by Zionua and Dillon, published in the Journal of Alzheimer's Disease. The key topic or principle, I guess, they've tackled is, what use are there for blood-based biomarkers in enabling differential diagnoses and prognosis at different symptom and disease stages? And really highlights the potential use of these blood-based biomarkers for neuropsychiatric symptoms across this continuum. In particular, whether it could be used in the early stages of differentiating neuropsychiatric symptoms from Alzheimer's disease and other neurodegenerative conditions, compared to mood symptoms from, say, primary psychiatric disorders. And on the bottom there, you see is the famous JAP curve. And I guess the question then arises, where does MPS and MBI sit in that framework? And how will the blood test assist in helping prognosticate and diagnose conditions in those earlier stages, which is critical given the emerging use of disease-modifying treatments like amyloid antibodies for the care of Alzheimer's disease. Changing tacks a little bit, now I'm going to be focusing on non-Alzheimer's disease biomarkers, and here focusing on Lewy body pathology. With advancements again in the blood test assays, now we can measure alpha-synuclein seeding amplification to quantify synucleinopathy pathology. This was an interesting one where there was 2 separate papers published within, I think, the same month, looking at different ADNI cohorts using the alpha-synuclein seeding assays. And consistently, both studies found that Lewy body pathology was associated with increased risk of developing neuropsychiatric symptoms, in particular psychosis and agitation. And the differences in both the papers was the population it looked at. One of the papers looked at amyloid beta positive population, whilst the other paper looked at the broader continuum, including MCI. And the insight and the implication is that there is better recognition that co-pathology is the norm, that Alzheimer's disease doesn't occur just in isolation, and looking at the broader biomarker spectrum may help yield or help us understand the diversity and the heterogeneity of how neuropsychiatric symptoms present. Now moving on to the second theme, rather than, I guess, accepting the heterogeneity of neuropsychiatric symptoms as the norm, the field now adopts a more nuanced approach, trying to link symptom profiles to specific neural circuits and their evolution over time. Previously, you'd hear sort of more common statements like 40% of people affected by MCI have depression. But now we're moving towards a field where it's not just about whether you have depression, it's about when you started having the symptoms, how it's changing, what symptoms are you having, what else is occurring that may help yield your dementia risk profile. And so this paper that I'll highlight, this is a large paper followed up for a long, long time. And it really establishes that certain depressive symptoms aren't just reactions to early cognitive decline. They are the manifestation of the neurodegeneration. And so this paper, over about 20 years, following up a large population, found that these key 6 symptoms related with depression had the highest sort of hazard ratio of those people developing dementia long term. And this really strikes true clinically too. Not all depressions that I see clinically are the same. There are some people who you just have a feel that this is something of a prodromal nature of dementia rather than a primary psychiatric disorder. And I guess the nuance of trying to break down these symptoms and trying to find the higher risk symptoms helps better understand depression as a heterogeneous construct rather than accepting that as a norm. This is a study that's looking at the other end, so in terms of brain systems, looking at using tau pathology, tau PET, technology to better understand the different subregions of the amygdala and how it might relate with cognitive decline and depressive neuropsychiatric symptoms. By following up presenilin 1 carriers, which is a cause of young onset dementia, they were able to identify the impact of tau burden in the amygdala without the confounder of older age. So a lot of these people, when they were started to follow up, was the mean age of sort of 40s and 50s. And it found that the tau in the basolateral amygdala was associated with poorer working memory, lower executive function, but also with greater depressive symptoms. And so this is an important study. It's the first to consider the clinical impact of tau PET pathology in the different amygdala subregions and really highlights how the advancements in biomarker technology has helped us have a better nuanced understanding of the mechanistic theory and the background behind neuropsychiatric symptoms. And with that in mind, I'll move on to the third theme. And this was a review paper by Schwab and many others, I'm sure, in this room, related with the neuropsychiatric symptoms PIA. That's really trying to highlight the heterogeneity that's inherent in Alzheimer's disease. That Alzheimer's disease is biologically cruel, that it's not cognition-centric, and how we can use multi-omics to try and reframe or how we better understand Alzheimer's disease and how it differently presents in different sexes, different co-pathologies, and different neuropsychiatric symptoms, with the ultimate aim, I guess, of trying to identify mechanistic targets for treatment. And so with that in mind, I've highlighted this paper here by Zhang et al. Published in Biological Psychiatry. This was from the CIBL, or the Chinese Imaging Biomarkers and Lifestyle Dataset, where they followed up 550 people, participants, both with Alzheimer's disease and cognitively normal. They broke down that individuals with Alzheimer's disease into different groups, including those with neuropsychiatric symptoms and not. And they used multi-omics approach, mainly using connectomes on neuroimaging, to identify the disruption of brain networks and see what groups were yielded from that, which they yielded sort of 3 or 4 different groups, and then matched up using this data-driven subtypes to how that correlated clinically. And what they found was that the groups who had more extensive network dysregulation had higher tau burden on plasma, had greater neuropsychiatric symptoms in terms of MPI total score, especially in the agitation and irritability domains. They also did a separate genomic or GWAS analysis, and they showed that these specific connectome-defined subtypes were associated with different genetic protein pathway signatures, and trying to sort of support the biological validity of these subtypes that they've identified. And so in summary, they've identified a data-driven brain network subtypes using connectomes, linked that genetically, and also shown that these subtypes correlated with different neuropsychiatric symptom severity. This next theme focuses on our ongoing efforts to move away from correlation to how neuropsychiatric symptoms are involved in the causation of dementias. Rather than just asking, or saying specific neuropsychiatric symptoms are associated with dementias, the field's asking when, how, and under what conditions they influence dementia risk, identifying what symptoms matter, what combination, and what stage of the disease. This is a paper by Zhang et al. In BMC Psychiatry, where they followed up 251 older adults with major depression over 20 years. And the key finding was that a depression onset after 75 years old had a significantly higher hazard ratio of developing dementia than those who were younger. So on the graph on the right there, in the yellow highlight is a group with major depression onset after 75, whilst those in the green are those with an onset at younger ages. Not only did their risk of developing dementia rise with their high onset of age, they also had a shorter time to converting to dementia over as well, sort of under 4 years compared to many more in the younger group. And so the interpretation here isn't that the depression causes Alzheimer's disease in this age group, but that the late onset depression is probably a prodromal manifestation of underlying neurodegenerative pathology. In other words, the depressive symptoms or the syndrome might be signaling these disease processes much more subtly that are already underway before the cognitive decline is evident. And this is a good example of how neuropsychiatric symptoms can function as a stage-specific marker. Earlier life depression might modify long-term risk, but very late onset depression appear to mark imminent conversion to dementia. And that really warrants different clinical care in terms of maybe more intensive follow-up, more cognitive follow-up, more investigations and counselling. As for the fourth theme, part of the heterogeneity in the neuropsychiatric symptoms research is that measuring can be subjective. Though there's emerging evidence or research using digital and continuous data sources to capture neuropsychiatric symptoms, the dominant way at the moment is using questionnaires and scales. And this varies from screening for all neuropsychiatric symptoms, like using the neuropsychiatric interview or the NPI, to specific MPS symptom measures like using the CMAI for agitation or the GDS for depression. And in this specific theme, there were two interesting papers looking at how we could better, or how should we be assessing or using these scales or tools to measure neuropsychiatric symptoms. And these two papers specifically focused on measuring agitation using the Cohen-Mansfield Agitation Inventory, or the CMAI. This is a caregiver-rated scale looking at 29 different agitation-related behaviours. And the original manual for the scale advises against using total score in interpreting the results because there are different domains depending on how you break it up in this inventory, including sort of physical aggression, non-physical aggression, verbal aggression, and so forth. Interestingly, though, this paper by Hendricks et al. Really looked at the data from 3 previous trials uh, that used this scale for measuring agitation. It again found that there were 4 CMAI subdomains that is consistent with previous research using a factors analysis. But it found that these 4 subdomains only covered about 50% of the total data variance, meaning it only explained half of the data on its own. So instead, it actually recommends against sort of what was stated in the manual initially, that using the total score might be a more meaningful, reliable, and consistent measure as a primary outcome. And then it recommends using the secondary descriptions of the relevant items depending on what they are. But this runs partially into the issue raised by another paper by Smith et al. In Frontiers in Dementia. And they conducted a qualitative interview with clinicians and caregivers using case vignettes and the changes in their CMI scores. And they found that what was clinically and personally meaningful in terms of change in these agitation-related behaviours was not captured accurately by their CMI total scores in all of the cases. In fact, salient behaviours like physical agitation or aggression, or physical aggression that could potentially result in harm was definitely more prioritized than the more indirect measures of that agitation and aggression, things like pacing and so forth. And so this sets up the central tension of the slide. Do we go for the statistically optimal outcome measure? That's the total CMI score. Or do we try and prioritize what clinicians and carer interpret as sort of meaningful and salient improvements in the behaviors? And I guess acknowledging those limitations of scales in mind, other research has been, advanced in terms of trying to measure neuropsychiatric symptoms using technology. Has the benefit of being objective, also can be quite continuous depending on what sort of tools are used, like wearables, radar, cameras, and so forth. And a lot of the research, but a lot of the research are still in the pre-translational phase, looking at sort of interesting devices, but hasn't been deployed or uptaken in real life. I did want to highlight one paper though by Professor Alboni in Toronto, Canada, that's actually released their data set on using multimodal methods to measure neuropsychiatric symptoms. And I think this is a promising and a great step for the research community to share data openly so that it can be reanalyzed, looked at slightly different ways, and maybe yield more interesting insights. Now, for the final theme I wanted to touch on was this evidence to practice. How do we improve the research base of neuropsychiatric symptoms and bring treatments to patients faster? There are randomized controlled studies that are underway, but it is relatively slow for neuropsychiatric symptom research. This was a paper in Nature Medicine that was a negative trial result for escitalopram in the treatment of agitation in Alzheimer's disease, which was, I guess, somewhat surprising given the effectiveness of citalopram from the CIT-AD study. I apologize, my slide's slightly askewed, but that's meant to be that escitalopram at the bottom is not equivalent or efficacious as citalopram. There are sort of 2 important take-home messages. One is that negative trials are important, I think clinicians without this research would have assumed that citalopram and escitalopram would have had similar clinical profiles and may have used escitalopram as an alternative if a patient didn't tolerate citalopram for any reason. But this touches, I think, on a broader issue, and that's being covered in depth by Jeffrey Cummings in this paper about the failures of clinical trials and the risks of a false negative trial if it doesn't adhere to strict and good frameworks. And so they published in the International Psychogeriatrics Journal a consort-based best practices guideline for trials looking at neuropsychiatric symptoms. And the key concepts or solutions they propose is using specific definitions that are trial ready for neuropsychiatric symptoms. And the IPA has developed in conjunction with other groups specific criteria for the major neuropsychiatric symptoms like agitation, psychosis, and apathy. Another recommended solution is making sure that the dementia diagnosis has been biomarker confirmed, especially with the advancements in blood-based biomarkers. That makes it a lot easier. Using outcome measures that are established and well standardized, that are syndrome specific, and also advocates for trying to address the generalizability of these research trials, ensuring that the population is diverse, that it's applicable in the real world. And the broad message is this, that MPS trials may not be failing because the symptoms aren't treatable, but because the biology of the circuits, the disease stages aren't sufficiently specified at this trial entry. And this provides a really important methodological rationale for why the field's moving towards a more rigorous and more standardized practice. So, coming towards the end, these are the sort of three fundamental ways that I've tried to summarize about how I've understood the field to have changed. First, that neuropsychiatric symptoms or NPS aren't just psychiatric or biological, aren't just clinical noises. They're actually biological signals that we can use to predict and validate what the underlying diagnosis might be. Secondly, we've moved away from, well, do they have depression, to asking, well, when did it start? How did it change? What else is changing? What else is happening? I guess temporal dynamics are critical. And lastly, we've recognized that the tools that we use to measure neuropsychiatric symptoms need improvement, need changing, and the way we do trials need standardization. I think the last paper by Cummings et al. Was of the consort-based approach is an important advancement to standardize the field. And so with these things in mind, it really shows how the field is evolving over time. And previously, in sort of clinical practice, we might have treated neuropsychiatric symptoms reactively. We might have waited for the symptoms, treated them empirically, and sort of hoped for the best. But now we're doing more precision neuroscience, especially in the research field, trying to predict symptoms before they appear, identify their biological subtypes, try and map their causal mechanisms, and match the treatments to their biology. And on that note, I should again really highlight there are so many other studies and themes that I could not cover today, and it really is exciting about how the field will change in the future. And so I hope I'd like to sort of acknowledge and thank the broader neuropsychiatric symptoms research community for their amazing contributions to this evolving field, including the MPS PIA. I'd also like to acknowledge those living with or affected with dementia with these research endeavors, really ultimately to lessen their suffering. Thank you everyone for listening and going on with me to this whirlwind tour of how neuropsychiatric symptoms research evolved last year. I look forward to hearing the insights from our panel members.
So thank you, Dr. Kang, for this thorough presentation on the most relevant literature from last year. I think that we heard most of what we expected actually, and a few other papers that might not have been so well known to us were also presented. We're still waiting our attendees to ask questions at the Q&A, so please don't be shy. You're free to ask questions for our panelists and our speaker. And while we don't have any questions, I'm going to raise the first question. It's for the speaker, but our panelists are welcome to submit their input as well. You presented several studies on objective biomarkers of neuropsychiatric syndromes, multiomics biomarkers, blood-based biomarkers, neuroimaging biomarkers. How do you see that in terms of outcomes? Do you think all that knowledge that is being accumulated is improving the outcomes of our patients? Are we treating them better? Are we having better results of therapy? Or do you see the possibility of that happening in the future? Or are we just accumulating knowledge that is helping us understand these diseases, but the outcomes are the same? How do you see that?
I think there are two parts to it. I think in terms of how we approach symptoms, and this is based on the literature search, but also my clinical experiences, how we understand neuropsychiatric symptoms clinically, or how we approach it clinically. When I see neuropsychiatric symptoms now, I definitely focus on sort of the temporal and the nature of longitudinally of these symptoms that help me stratify the risk of what the underlying condition is. Is it a dementing illness underneath, or is it a primary psychiatric disorder? Because the treatment trajectory is so different depending on which way that goes, and the follow-up so different. I haven't, unfortunately, there's no research that shows that can clinically, objectively, meaningfully measure that in terms of, did this person have a better outcome because I did biomarkers early or not? On the other side, though, in terms of treating neuropsychiatric symptoms, I don't think we're doing anything much better yet. I don't think it's translated to sort of real-world improvements in identifying, the cause of apathy in Alzheimer's disease, and this is the treatment for it. I don't think we've gotten to that sort of mechanistic level yet that's yielded actual results. I'd be curious to hear the panelists' opinions.
Thank you. Do any of our panelists want to speak?
Yeah, I'm not sure if you're seeing our hands, Fabricio, but it's one of those important questions to ask, whether the jump to the biomarkers of Alzheimer's disease and trying to kind of almost prove that these psychiatric symptoms are part of the neurodegenerative illness is where we're at now. But I don't think this is. It helps us in diagnosis, as you know, and making sure that we offer people the option of looking at disease-modifying therapies, for example. But I'm not sure if it is a precision tool when it comes to what network is impaired and what mechanism by which that network is impaired. Like, for example, if you're treating apathy, now we know that we have used our kind of understanding of dopamine, and we have Ritalin trials. Is one example of that. And well, we do SSRIs for depression, and that's still based on the assumption that those networks are being affected, and there's some evidence, of course, of changes in cells, number of cells producing serotonin or dopaminergic transmission. But I still don't see that precision, being like. So why can't we image those components or find a way to detect those components so that we can say that you are now in a just simplistically, you're in a serotonergic deficit state, as evident by this particular parameter, and therefore I'm going to see if I can correct it, but also prove that that correction is there. Like the way we're targeting amyloid now in Alzheimer's disease modifying trials, we can actually say that yes, we intended to target amyloid, we found it, we targeted it, we removed it, and now we're looking at the symptomatic improvement. So I just feel like the precision. I'm glad to see the surge of activities that are happening in the field, but I do believe that we need to start looking into what precision we need to implement to be able to target. So that's just my bias in this area.
Thank you, Amir. I also see the hand of Muranarsh.
Yes, thank you. That was a really fascinating overview, Matt, and I learned a lot from your presentation. I think just to echo the comments from Amir, from my perspective, where we're looking at mechanisms and trying to understand how to target some of these symptoms. I think one perhaps promising avenue is that we shouldn't be treating these symptoms as distinct or like isolated entities. In fact, a lot of these neuropsychiatric symptoms are actually products of underlying shared neurobiological substrates, and the mechanism seem to overlap in terms of what's driving apathy, what might be driving anhedonia, what might be driving compulsivity as well, which was one theme that I noticed didn't really appear at all in today's overview, is these ideas of ritualistic and stereotypical compulsive behaviors. And so from our perspective in the frontotemporal dementia arena, these are highly distressing features that carers often report as being far more troublesome than maybe some of the other symptoms that we have tended to focus on. And so I think we really need a coordinated, concerted approach where we're trying to identify common and unique mechanisms that might be kind of differentially contributing to some of these symptoms, but also working with people with lived experience to understand if we're targeting this feature, is that going to help you in your daily life? And then obviously, as Matt has alluded to, taking longitudinal approaches to understand the evolution of these symptoms. Do some of them ebb and flow? Do some become more sort of prolific over time? And are we targeting what our patients and our families need us to target?
Thank you. I agree with most of what has been said here. I just wanted to point out that my question was because most of the articles that Matthew presented and some earlier articles from 2020, 2021, they usually end up concluding that these biomarkers can be used in future clinical trials. And I'm sure that that's happening yet. As Amer pointed out, amyloid has been used a lot, but not other biomarkers that we sometimes see in articles that are not very well studied. So I hope that for the future we can have better outcomes because of those biomarkers, because I think that many of them are just accumulating knowledge for us. But we already have a question in the Q&A. Nicole Björklund, she asks, what limitations have you seen for people with NBI participating in clinical trials? Are there alternative trial designs that might allow participation more broadly? So who'd like to answer that? Ganesh is still quiet. Would you like to say something?
I'm quiet. I'm certainly, I can take a stab at that. I think it's a fantastic question. Sonny Franzen and I and a few others, we published a paper a few years ago looking at diversity in clinical trials, particularly in AD-RD, and most of them focused here in the United States, but unfortunately there were other studies occurring elsewhere. And unfortunately, I think NPS and individuals with other types of mood disorders are unfortunately treated as sort of a nuance that needs to be screened out and factored out. It's noisy, and as a result, they're looking for a more pure, very clean sample. And I think that's deeply problematic for so many different reasons. And so one of the things that we advocated for, and we're following up with a second paper, is we need to broaden the inclusion of all types of individuals being included in clinical trials, and particularly in terms of the anti-amyloid treatments that are coming down the pipeline right now. And I think it's critical for a number of reasons, but I think chief among them is that the population is heterogeneous, and that heterogeneity is only going to rapidly increase with diversity in a more globalized world. And so by working to get these very clean samples, especially for your phase 0s, 1s, and 2s, by the time it reaches efficacy, we'll start to see some failures. And so I'm not sure if that requires an alternative pathway and an arm for clinical trials. I think that's left up to the potential funders, clinicians, and in addition to the clinical coordinators that are conducting the studies to ensure that folks are coming into the clinical trials to get the treatment. But that's just my 2 cents.
Thank you, Ganesh. Amar has raised his hand.
Yeah, that was a great question, and also a great answer by Ganesh in terms of really finding a way to include without losing the ability to detect the signal, obviously, in a trial where people fortunately don't have unlimited resources to run trials, and these trials are including thousands of people. But it's even more troubling to me that even the trials, like I think Matthew did, show the ISTAART trial. I was part of that trial and the authorship. We had significant struggle getting people into that trial when the target is neuropsychiatric symptoms. So this is where you're saying, you know what, you need care. We're here to provide this care. And it was designed in a very naturalistic way, provided psychosocial intervention for several weeks. And only if those fail, we randomized people to escitalopram versus placebo. If they responded psychosocial, we continued, and we didn't really drop anybody. So in a way, I mean, there is that component of not being included in disease-modifying therapy, which I completely agree with Ganesh, that this need to be solved either by giving people access to other trials to behavioral symptoms, then get them to disease-modifying if they have a proven, amyloid status, but also in those trials that are particularly targeting behavioral symptoms. So there's still, I'm not sure if the stigma is a stigma from people with lived experience and their caregivers. I don't think that's the case, but I think maybe we need to target our own colleagues as well, who are themselves not taking the opportunity of connecting to these trials, and they assume that, we can throw in a bit of citalopram, and you end up with this mixed bag of treatments that are not, none one of them is completely evidence-based. So I'm actually a victim of that the stigmatization. We struggle so much to recruit to behavioral trials when it's really meant to help people.
Last, Catherine, would you like to add something?
Yeah, I mean, I always think about this. I haven't worked just directly with clinical trials over the last few years, but I do think there are some limitations even from a research perspective. I know we've had some struggles where people are experiencing quite a few neuropsychiatric symptoms, but there are also safety limitations with involving them in research trials. So it gets very sticky if someone has active suicidal ideation or is behaving in a way that could lend themselves to be a harm to themselves or someone else. We've had trouble with kind of like manic-like behaviors in individuals, especially I think, and Amara just mentioned this too, there needs to be such a buy-in from care partners and family, especially if we're going to manage that. And I think that's where we're also running into issues, is that many of these older adults are alone, or they don't have people who can come to a lot of these appointments. And that really makes it even harder to get them into these trials, or the care partners are just swamped with appointments and things like that, and getting them into a research study is the last of their concerns. So it's something I've thought about. And I definitely think there are a lot of crises kind of compounding onto each other, and I'm not entirely sure how to fix it, but I'm glad we're getting to noodle on this together, because there's a lot of great topics. And I think we're all kind of reaching from different disciplines, saying we're all having trouble in this way. How can we kind of put our heads together and fix that?
Yeah, I agree with the comments of all of you. And I believe that this last part that Catherine mentioned about the caregiver burden is something that really limits the participation of patients in such clinical trials. But I would also like to comment on the previous discussion that we were having about the importance of studying neuropsychiatric symptoms across diverse dementia syndromes, which is something that Dr. Khan mentioned previously of the year. And I'm sorry about the pet here. I think that studying neuropsychiatric symptoms should be done across all the dementia syndromes, not just Alzheimer's disease, because all these impulsivity and apathy and all these behavioral symptoms tend to appear also in different syndromes that we may be using them or measuring them in terms of endophenotypes, something that is quite used in research in psychiatry, and maybe that could also help increase the signal that we can get from studying these patients and these populations, and understanding better how to tackle them in diagnosis and both in treatment.
I think that also aligns really nicely with the revised criteria, where there's a lot of suggestion that mixed pathologies are probably the norm for a lot of people, and we don't really know how that manifests clearly with neuropsychiatric symptoms. So we do need to be studying other biomarkers in tandem. How does alpha-synuclein impact this, or vascular pathology, things like that, as both of those proteins are protein, alpha-synuclein, and then vascular pathology are associated with their own neuropsychiatric symptoms. How is that intermixing with AD pathology as well? And I don't know that there's enough research in that area yet, but hopefully with the revised criteria, we start to see more studies, unless other folks here have been doing that research and want to share.
Yeah, maybe just a quick comment on that. You're probably familiar with the COMPASS-ND database in Canada. I think this has been at least our largest attempt to and it does include normal cognitively normal individuals, MCIs of Alzheimer, but also MCI of other so each of the trajectories toward cognitive disorder is included, including of course Lewy body and Parkinson's disease, FTD, and so on. So as we speak, there's actually a lot of data requests now that are going to the Compass ND database to ask some of these questions in terms of what are some of the biomarker findings in, let's say, somebody who's presented with MCI with significant vascular burden. Those who are Parkinsonian MCIs in a way, because we have some. Oh, sorry, it's my hospital having code white. So hopefully you still hear me okay. It's not too much noisy. Yeah. So basically, people like we have Dr. Richard Camiccioli from Edmonton, who's leading for some of the Parkinson and Lewy body MCI, from MCI all the way to the full manifestation, and looking at the biomarkers. So I think I'm not familiar with other databases. I think the ADNI does it include other? Because I'm thinking like these are some of the questions that we all have to be asking in terms of what are some of the ways to actually detect earlier manifestation of illnesses like Lewy body, like Parkinsonian manifestation, including PSA. I know that plus you did work with Mario, I believe, and Carmela in Toronto, and that's their area of work. So they're asking those questions from our database, but I'm sure there's other opportunities to ask those questions.
Yeah, and just for those looking for resources, ADNI does have some information. They do have an alpha-synuclein assay that is relatively new. I believe it might only be cross-sectional or more limited longitudinal data. NAC, I don't think has that, but they have autopsy data in a subset of individuals. And, as I said, the alpha-synuclein assay is pretty new. And I know there's skin biopsy tests as well, though I think the skin biopsy, from what I've heard, is a little less sensitive in preclinical phases or those earlier phases versus the assay for CSF. So I think that brings up another discussion that might be a good collaboration in the future, that we just also need biomarkers for some of these other pathologies that are a little more sensitive earlier on as well. Though certainly autopsy studies are very rich. Ganesh, I see you unmuted if you want to chime in as well.
No, I think that's a great point that you brought up. And I think what we need to start focusing on is broadening the horizon. And there are a number of different platforms available. One of the things that we're focusing right now, and this is certainly not any endorsement, but LMR's new LISA 120 CNS panel. And so we're taking a look to understand what are the different factors perhaps that might be associated with different etiologies, how prevalent are specific neuropsychiatric symptoms. But we don't want to stop there. I think one of the things that Dr. Kang pointed out in his talk was there is a significant shift towards technology. And as I'm sure, we're not all immune to AI and the shift towards machine learning. But starting to stitch together, I think, tools and sensors that measure functional outcomes. So, whether that's gait or eye tracking or driving or other aspects, to understand how are these impairments actually playing out, not just in the real world, but also in real time. And then combined with the biological markers, we can have a much more robust, as close to as a 360-degree view of the individual, but also how they're changing over time. And I think that's the issue, is the current paradigm is predicated on one time point, whether you're seeing the individual in the clinic once a year or every 18 months. That could influence a whole host of different factors, but that multiple sampling, in addition to the biological sampling with plasma that's affording, I think, been helpful to start to shift the needle a little bit to increase the precision and the accuracy that we need to understanding the effects, not just within, I think, clinical trials, but also just aging in place.
Maren, you have your hand raised.
Yeah, I just wanted to come back to Blas's comment, because I think it's really important that we start to adopt these transdiagnostic perspectives and view these symptoms as multidimensional rather than just a presence absence or occurring at a single time point, as Ganesh has just said. And I know we are sort of shy of the heterogeneity, but in fact, the heterogeneity offers us a huge opportunity to conduct really big studies where we can harness the group differences and use more sophisticated approaches like clustering, deep learning, to really pull out symptomatically who is showing what particular expression or symptom or severity, agnostic to their actual diagnostic label. And I think that's really important, because the work that we're doing in my team at the moment is showing that people don't cluster naturally into their diagnostic labels, but rather they're showing different sort of phenotypes in terms of the symptom itself. And so we might be sort of throwing the baby out with the bathwater if we keep trying to put people into their diagnostic categories rather than taking a more symptom-driven approach. And I think hopefully that's where the field will shift, and we can come together with more fine-grained tools to really understand that you can have Alzheimer's disease or you can have frontotemporal dementia, but a whole confection of different symptoms at different times.
So we still have 5 minutes to go. Do we have any other questions? Do the panelists want to ask each other questions? Any other comments regarding? Sorry.
Yeah, I just wanted to raise as well that I mean, part of what people are alluding to as well is like different way of understanding these symptoms and profiling them. We are now actually doing a Delphi study through the MPS. This is a brain stimulation and biometrics group. Sanjeev Kumar and myself are trying to survey really our expert group and their networks in terms of what are the peripheral and central physiological markers that could help us as well start honing into the network involved, because as you know, chemistry and electricity operate these networks, but these networks can be impaired in different ways in these syndromes, and try to understand that may also help us start targeting them directly through brain stimulation, for example. So as Krista Langto and I are part of a study that looks at targeting networks for apathy, for example, as a way to augment the effect of Ritalin. So that's another way of actually imaging and creating biomarkers. So, I would love to see input from all the experts around. And we have already 25 people responded, so that's great. And we'll continue to push to see whether we can reach consensus on what is, and that actually, to your point, Ganesh, that this is now more alive because of advanced analytics and AI, because the noisy signal that you get from things like EEG and wearable devices, it get more and more readable as you start using advanced analytics. Not only AI, classic AI, now quantum AI start showing up as well, and we're hoping to be able to have more clarity.
Thank you, Amer. We have one last question from the audience. Dr. Daniel Fisher is asking, do we think the current studies on NPS have the right balance of rigorousness in terms of clinical phenotyping and cellular molecular analysis? If not, which is more imbalanced? Who wants to answer that?
The answer is no. At least to start with, I don't think we're all, we're not comfortable, at least I'm not comfortable to see that we're as rigorous as we should be. And I think Matthew did point out the effort to kind of refine the definitions. For example, Zainur Ismail and group did bring the Cohen-Mansfield into a little bit more, proximity to the IPA definition of agitation. That's one example. But I think, in the last IPA meeting, the International Psychiatric meeting, there was groups that worked on trying to define more of these criteria. So that's my observation, that we're still far from precision when it comes to rigorousness for the target, but others probably will have other thoughts as well.
No, I completely agree with you, Amara. I think the cellular and molecular analysis has certainly lagged immensely. But I think, as Marin mentioned, we really can't throw the baby out with the bathwater. It's really quite critical for us to focusing on both, but understanding where things are. Because I think, we can probably all agree, in 2030 and 5 years from now, it'd be lovely to have NPS as a primary target in terms of like hypertension or hyperlipidemia, right? Those are the things we want to be able to screen clinic-wide. And so I think a lot more work that needs to be done. I know we're getting it towards the end of time.
Just on that point, Ganesh, we are working, at least in my lab, on making sure that we co-design our questionnaires and our scales with people with lived experience. And that includes people living with dementia and their carers. And we've developed a couple of new tools, and hopefully we'll be able to showcase at AAIC and maybe offer new ways of kind of distinguishing between apathy, depression, anhedonia, and these compulsive behaviors, which all seem to be reflecting a common underlying mechanism.
So thanks, everyone. I'll leave the last words to Daniela.
Thank you. Thanks so much, Fabrizio. Thank you so much, everyone, to our speaker, Dr. Matt King, and to all of our panelists for facilitating such lovely discussion and insightful questions. Thank you all so much for attending today's session, and I hope to see you in future MPS-PS sessions.
So much.
Thank you. Bye-bye.